Good afternoon, everyone, and greeting of the day wherever you are. My name is Jamal Aljubeh. I'm a pediatric endocrinologist at Sheikh Khalifa Medical City in Abu Dhabi. I would like to thank the organizing committee and in particular Dr. Wiam for inviting me to participate in this conference. I wished I was with you physically, but for some circumstances I have to do this virtually. So we are going to talk about rickets, and I will cover a review of the clinical presentation, explain the radiological findings, interpretation of the lab results, understanding the pathophysiology of different types of rickets, management of the different types, and a little overview of the X-linked hypophosphatemic rickets. So the main manifestation of rickets is skeletal in the form of deformities in the bone and abnormalities in the bone, in addition to bone pain. However, in addition to that, there is also hypotonia and muscle weakness in most patients. There is a decrease in linear growth. There is developmental delay, respiratory infection due to restriction of the lungs, as well as other manifestations. So the deformities that happen in rickets most commonly come in the form of genovarum or bow legs. However, some patients may develop genovalgum or knock knees. This happens more often in the older children, not in the 1 to 2 years of age, and rarely the wind-swept deformity that you can see. Craniotabes is softening of the skull bone. Frontal bossing can be obvious as in the shown picture. Widening of the wrist. We can also see widening and deformity at the ankles, as well as rachitic rosaries at the costochondral junction, and Harrison sulcus in the area below the ribs. The radiological findings you can appreciate in these pictures in the metaphysis that there is cupping and fraying and eaten away metaphysis. And you can also appreciate the deformity that you can see here in the lower extremities. So in the pathophysiology of rickets, it's important to understand the role of apoptosis of the hypertrophic chondrocytes. This apoptosis is actually something very good for the body. It's very important for the apoptosis to happen in order for the normal bone mineralization to occur. And for all of this process to happen, the bone needs adequate amount of phosphate. So low phosphate or any inadequacy of phosphate will inhibit this apoptosis and inhibit the mineralization. So low phosphate is essential part in the pathophysiology of all types of rickets. So pathogenic basis for rickets can be either inadequate calcium or calcipinic, or inadequate phosphorus or phosphopinic. And notice that I didn't call this hypocalcemic and hypophosphatemic, because sometimes inadequate calcium can be associated with normal calcium in the blood and not necessarily hypocalcemia. So the inadequate calcium or calcipinic rickets is mostly related to vitamin D in the form of vitamin D deficiency, a defect in vitamin D activation, the formation of 1,25-dihydroxyvitamin D, or a problem at the level of the vitamin D receptor. So this type is vitamin D dependent type 2, and the one with the activation is vitamin D dependent type 1. In addition, calcipinic rickets in some circumstances can also be due to deficiency in dietary calcium. And that can happen sometimes either on inadequacy of oral calcium, or patients who are dependent on TPN if the calcium is not adequate. How about the inadequate phosphorus or phosphopenic rickets, where the primary problem of the rickets is lack of adequate phosphate? This can be divided into subtypes. So there is the renal phosphate loss due to excessive FGF23. So renal phosphate loss in general is the most common type, the most common cause of phosphopenic rickets. It can be associated with abnormality in FGF23 or not. The ones associated with FGF23 elevation include the hereditary rickets, including X-linked hypophosphatemic rickets, autosomal dominant, autosomal recessive, and neoplasms that produce FGF23. These are usually benign mesenchymal neoplasms, and they are difficult to diagnose and find. Also, bone and skin disorders like McCune-Albright syndrome and certain types of nevi. Renal phosphate loss due to a defect in NTP2C is hereditary hypophosphatemic rickets with hypercalciuria. In this condition, the 125 hydroxyvitamin D is elevated as opposed to the FGF23 dependent, in which the 125 is decreased. Also, always important to remember renal tubular defects, renal Fanconi syndrome. So whenever we find a case of hypophosphatemic rickets, we do a urine dipstick to look for that. Inadequate phosphate intake is not very common cause of rickets because phosphate is really abundant in most types of food. Some circumstances in which there is inadequate phosphate intake include premature babies who need relatively higher amount of phosphate. It also includes patients with short bowel syndrome on TPN if the amount of phosphate is inadequate. There were also reports of inadequate phosphate on infants on Neocate formula. For some reason, this formula interferes with the bioavailability of phosphate. So the main source of vitamin D naturally is through synthesis in the skin after exposure to the ultraviolet light. In natural foods, vitamin D is not easily and commonly found. So most of the foods that are rich in vitamin D are foods that are fortified or supplemented with vitamin D, with the exception of fatty fish and fish liver. The problems with vitamin D, it can be, as mentioned, either deficiency or through a problem with activation from 125 to 125 dihydroxyvitamin D, or at the level of the receptor. So when we face a case of rickets, we start doing laboratory studies, and it's important for us to interpret these correctly. One of the first studies we do is alkaline phosphatase, and in rickets, alkaline phosphatase is always elevated. So if you have a patient with skeletal problem with alkaline phosphatase is low, then we think about hypophosphatasia. If the alkaline phosphatase is normal, then most likely this is not rickets. It can be skeletal dysplasia or Blount's disease or something else. In cases of phosphopenic rickets, the alkaline phosphatase is moderately elevated, and in cases of calcipenic rickets, it is typically very high. So phosphate is low in all types of rickets. In phosphopenic rickets, it's the primary problem. However, even in the calcipenic rickets, the drop in calcium leads to elevated PTH, which leads to a drop in phosphate. And the management can be different for sure. It's important to notice that the normal level of phosphate varies per age group. So the young infants have a much higher phosphate level than older children and adults. Some of the labs, unfortunately, do not reflect the appropriate reference range. When we look at the phosphate, we want to know how much of phosphate is excreted in the urine. And as I mentioned before, most conditions of phosphopenic rickets are associated with increased phosphate loss. So the fractional excretion of phosphate in this case is increased or the fractional reabsorption of phosphate is decreased. However, if the phosphate in the urine is decreased, then this indicates that this patient has a nutritional deficiency of phosphate. In all other types, the phosphate in the urine will be increased. And one important formula is the maximum tubular reabsorption of phosphate over GFR. There are many applications and electronic formulas to calculate this. Other labs we do include the parathyroid hormone, and it helps us to differentiate when the PTH is clearly elevated, then we are almost always dealing with calcipinic rickets. However, with phosphopenic rickets, PTH is normal or at the upper border of normal. Calcium in calcipinic rickets can be either low or normal. In some of the severe cases, it can be very low, but it can be also normal. However, if the calcium is low, that excludes phosphopenic rickets, in which calcium will always be normal. It's important to look at the albumin or ionized calcium so that we avoid incorrect diagnosis of hypocalcemia when only the albumin is low. Then always important to look at the kidney disease, because patients with chronic kidney disease may have many abnormalities that are resembling those that we find with rickets, including abnormalities in calcium and elevation in PTH. However, in kidney disease, usually the phosphate is elevated, while in rickets, the phosphate is decreased. Metabolic acidosis is associated with certain types of rickets as well, especially with the Fanconi, where there is loss of alkali in the urine. Hypokalemia also happens in Fanconi due to loss of potassium. In the urine, we also measure the calcium creatinine ratio to know if there is hypercalciuria or not, and a urine dipstick, as mentioned, to look for possible renal Fanconi syndrome. 25-hydroxy vitamin D for the diagnosis of vitamin D deficiency. 125-hydroxy vitamin D is not easily or routinely available in many labs. If we are suspecting nutritional rickets, then we don't need to do it. But if we are suspecting other rare types of rickets, then it will be very helpful. In phosphopenic rickets, one might consider measurement of FGF23, fibroblast growth factor 23, which can be elevated in conditions like XLH. However, in some of these conditions, it can be also within the normal range, but it's considered to be inappropriately normal, because in the situation of hypophosphatemia, it should be normally suppressed. Of course, genetic testing can be the last resort to reach specific and clear diagnosis, especially in the rare genetic conditions. So to go over a case, this is a patient who came to us actually many years ago when he was 1.5 years of age. As you can appreciate, very severe rickets with eaten up metaphysis. You cannot even see the definition of the bones, as well as fractures shown here in the femurs. This is the upper arm. You can see multiple fractures in the humerus, severe rickets as well everywhere. Again, this is the forearm with fractures in the radius and ulna, and severe rickets, whether you look at the elbow or whether you look at the wrist. So we investigated this patient. His electrolytes were normal. His BUN and creatinine were normal. Alkaline phosphatase was elevated as expected, which is consistent with rickets. This level is going more with calcipinic rickets. as well as the X-ray findings are going with calcipenic rickets, because with phosphopienic rickets, the findings tend to be relatively milder. You cannot appreciate that severe rickets and severe osteopenia on the X-ray. Phosphate in this patient was low, but as mentioned, phosphate can be low in all types of rickets, so that's not a differentiating level. Calcium was very low, and ionized calcium was very low. So now we know for sure that this is a calcipenic rickets, and we know that it's a severe form of calcipenic rickets. The parathyroid hormone was extremely elevated, again going with severe calcipenic rickets because of the deficiency in calcium will stimulate the parathyroid hormone. 25-hydroxyvitamin D was low. However, we should not be deceived by that. I'm sure you know from your practice that a mildly decreased vitamin D or 25-hydroxyvitamin D level is commonly seen in all patients walking in the street. So this mild decrease in 25-hydroxyvitamin D cannot ever cause severe rickets as we saw in this patient. So this is an incidental finding. We treat it, yes, but we have to, it's not adequate just to give this patient vitamin D. 125-hydroxyvitamin D was very high in this patient. So this was going with vitamin D dependent rickets type 2 due to resistance at the receptor level. Interestingly, last month we have seen a patient with all of the features are exactly the same as I described. All of the laboratory findings were very similar, with the exception of 125-hydroxyvitamin D being low. So the clinical picture can be very similar between those who are having activation of vitamin D and those who have resistance at the receptor level. In this patient, genetic testing confirmed mutation in the vitamin D receptor. The treatment for this kind of case is not very easy. So these patients will not respond to normal treatment with oral calcium and vitamin D. These patients, especially with this severity, will need continuous calcium infusion for long periods of time. So we placed a portacath and started long courses of continuous intravenous calcium infusion, which gave excellent results, but the treatment is a lengthy treatment. We had to treat for several months with intravenous calcium intermittently, and then place the patient on very high dose of oral calcium as a maintenance once the rickets has healed. You can appreciate here some of the images before and after, where you can see significant improvement in the shape of the bones and resolution of the rickets and healing of the fractures. You can see that there was still a little bit of deformity. These deformities, most of them, they correct themselves with time, especially in a child who is growing. So with the growth, most of these deformities will not require any surgical intervention. You can see the same here in the wrists before and after treatment, as well as in the lower extremities with healing of the fractures and healing of the rickets. And this is the growth curve for this patient, showing also significant improvement of the growth once we treated the underlying condition. We did not have to use growth hormone or any other modality to manage the growth. As you can see, when we put the patient on intravenous calcium, this gives you how the response is. So the PTH will drop gradually to the normal level. The alkaline phosphatase, which was rising before the intravenous treatment, also was responding to the treatment. This is actually not the initial treatment that we gave for the patient in the initial presentation. This is another course of treatment that we had to give during adolescence due to the rapid growth. His rickets was worsening again, and he required another course of intravenous calcium. That's why the alkaline phosphatase is not as high as it was before. The calcium level improves gradually with the intravenous calcium treatment, but without causing any hypercalcemia. So a few points about vitamin D. So for patients who are vitamin D deficient, we use either vitamin D3 or vitamin D2. Both of them will do the job. D3 tends to be a little bit more potent with more bioavailability, so you can achieve the same results with relatively lower doses, but either one and the appropriate dose will do the job. Calcitriol and alpha-calcidol are active form of vitamin D. They should not be used for treatment of vitamin D deficiency, but they should be used for patients with vitamin D-dependent rickets, as well as patients with hypoparathyroidism and pseudo-hypoparathyroidism, and some of the renal patients as well. Let's go to case 2 for a different type of scenario. This is a 4-year-old Emirati boy, first seen in the endocrine clinic at the age of 3 years, referred from orthopedic clinic for abnormal, for deformity in the limbs. Normal pregnancy, and the past history in the neonatal period was unremarkable. Relatively delayed walking. Deformities involving both legs noticed a couple of months after walking. No other significant past medical history and no known family history of rickets. 2 healthy sisters. However, the mother had a history of orthopedic surgery for lower limb deformity around the age of 20 years. So it's important to remember this piece of information. Patient was seen by general pediatrician who diagnosed with vitamin D deficiency rickets and started treatment with ergocalciferol. This is commonly the case. Initial endocrine evaluation, healthy looking boy, short with a height of -3 standard deviations, waddling gait, chinovarum deformity, and wide wrists. This is the X-ray of the patient. You can see and appreciate Rickets findings where there is widening of the metaphysis and there is also cupping and milder degree of fraying. However, if you compare the X-ray of this patient with that of the previous one, you can see that this disease appears to be much milder, and the density of the bone appears to be much better. And this is typical of the phosphopenic or hypophosphatemic rickets. Again, mild abnormalities in the metaphysis of the radius and ulna. So the labs showed normal renal function, corrected calcium was normal, phosphorus was very low. Alkaline phosphatase elevation was mild, 542. And again, this is typical of the phosphopenic rickets where ALK-phos is not very high. PTH was normal, 25 hydroxyvitamin D was normal, and 125 dihydroxy-D was also normal. Blood gas was normal, urine dipstick to rule out Fanconi was negative, normal urinary amino acids, tubular maximum reabsorption of phosphate and was decreased. So there was decreased in phosphate reabsorption on 2 occasions. Diagnosis was hypophosphatemic rickets. Patient was started on calcitriol and phosphate, which is the conventional treatment of rickets, but there was poor adherence. Evaluation for other comorbidities like dental, orthopedic in general, ENT, MRI of the brain, and ultrasound, all of these came back normal. Genetic testing showed a mutation in the FIX gene, confirming the X-linked hypophosphatemic rickets. His mother was also having the same mutation. So the mother had hypophosphatemic rickets all her life and was never diagnosed before, even though she required orthopedic surgery. So the patient was started on the new treatment, burosumab, 10 milligram subcutaneously every 2 weeks, was tolerated well, and showed significant improvement regarding the gait and deformities, and the phosphorus level normalized. So a few slides on the X-linked hypophosphatemic rickets. It's caused by a mutation in the FIX gene leading to elevation in FGF23. FGF23 role in physiology, it actually leads to increased loss of phosphate in the urine, as well as a decrease in 1,25-dihydroxyvitamin D. So an elevated FGF23 will lead to hypophosphatemia and decreased activation of vitamin D. It's X-linked dominant inheritance. However, 20 to 30% of the cases will be caused by spontaneous mutation without inheritance from the family. FGF23 mediated hypophosphatemic rickets, the most common type is the X-linked dominant XLH, but there is also autosomal dominant or autosomal recessive with the same pathophysiology. They are associated with the teeth abscess, the skeletal deformity, a decrease in growth, and sometimes Chiari malformation in the brain. The conventional therapy for hypophosphatemic rickets is to give them a combination of phosphate supplement as well as calcitriol. Phosphate needs to be given at least 4 to 5 times daily, because every time you give phosphate, it will be lost in the urine. This makes adherence to treatment very challenging. Some patients may, with the Knock-knee deformity, may require surgical intervention to stop growth on one side of the leg and allow growth on the other side to correct the deformity. This is an example of one patient who was treated in this way. So borosumab is a monoclonal antibody against FGF23, so it will neutralize FGF23 and stop its action and reverse it. This will reverse the hypophosphatemia and the drop in 1,25-dihydroxyvitamin D. In trials in pediatric patients, it showed improvement and normalization of alkaline phosphatase, normalization of serum phosphate fasting, normalization of the reabsorption of phosphate in the kidney, as well as improvement in the ability to walk, the amount of distance walked in a 6-minute period in patients with rickets. This reflects the functional improvement. So in conclusion, it is essential to maintain bone health by adequate calcium and vitamin D. Rickets can be devastating disease in some of the severe cases. Correct diagnosis is important for proper management. Follow-up is essential to monitor response and adjust treatment. Borosumab as a new therapy neutralizes FGF23 and leads to clinical improvement in FGF23 mediated rickets. Thank you very much.